All right, guys, here's our last section for this next circulatory exam, which is ACS, which is the fancy way of saying heart attacks. So acute coronary syndrome is our medical word for heart attacks or myocardial infarctions or all those fancy terms for the same kind of thing. So let's get into it. Pathophys, so what is going on? So there's an again, my mouth can't say that word. There's a plaque buildup in the coronary arteries. This is the thing I can't say, atherosclerosis. It's that narrowing of the blood vessel, but this is a blood vessel or an artery that's feeding the actual heart tissue. So the muscle tissue of the heart, not the interior lumen, but outside the heart. This increases the risk for a thrombus or a clot whenever there's that narrowing, kind of like we've talked about with peripheral artery disease and AAAs. So the main symptom or the main thing that is going on is there is tissue death. Tissue death equals pain. So as long as patients are having chest pain, they are having tissue death, and that is a bad, bad thing. So the way that people have heart attacks or some of the factors that increase their risk for heart attacks go into a couple categories. There's modifiable factors and non-modifiable risk factors. The modifiable ones are things like their cholesterol levels. So based on dietary intake, HDL and LDL levels, which are high density lipoproteins and low density lipoproteins. Blood pressure management. So uncontrolled hypertension is a big one. Smoking, because nursing school and smoking is the root of all evil. And weight management. Weight management, in particular, this kind of weight management. We call this like visceral fat, where patients have a lot of core abdominal weight. That central obesity really is like one of those hallmark presentations of patients who are very high risk for MIs. You know, you look at that belly, you just want to kind of pet it a little bit. It's super weird. But that kind of body posture or kind of shape is very, very high risk for patients having a heart attack. Some non-modifiable risk factors, things like age. So as people get older, there's more time for them to develop plaque in their coronary arteries, making them high risk for heart attack. Gender tends to run more in men than women, but we are starting to see data that it is more equitable between men and women. Just the presentation is very different for women than it is men. Race, genetics. So again, all the things we can't change. Your age you can't change, your gender you can't change, or any of that other stuff. You can't do anything to affect that. So those are our non-modifiable risk factors. Yay, some more public health. So heart attacks are not equally distributed across the country. We are right there. That little pink spot is Denver County. So in Colorado, we are actually doing pretty darn awesome about reducing our risk of heart disease and death associated with heart attack. Other places, the South, not doing so awesome. Up into the Midwest, the Rust Belt area of the country, also a little bit higher risk there. So there is an unequal distribution of people exposed to this health risk across the country. So if you guys do tend to practice in other parts of the world or other parts of the US, do keep in mind that unless you're going to Minnesota, you're going to encounter higher risk of heart attack than you do in Denver where you're here training. So do watch out for that because it is a big issue worldwide and nationwide. So for assessment stuff, a big thing we're trying to figure out is this an acute or a subacute presentation of chest pain, changing our level of suspicion for them having an actual heart attack. So one of the things we're trying to figure out is acute chest pain is persistent, so continuous chest pain for 30 minutes. Meaning that from time of onset to time of presentation, they have had persistent continuous pain that has not changed or been relieved with periods of rest versus activity. So that intermittent claudication presentation is not present. We also look for that for our subacute type of chest pain. So they have intermittent claudication. These, in Colorado, one of the big times we see these subacute ACS presentations is in the winter when people are out shoveling their driveways or the sidewalks. They develop chest pain while they're shoveling snow, but then when they stop, then their chest pain goes away. So that's our intermittent claudication presentation of acute coronary syndrome. And then, is it stable or unstable? These are terms that we also ascribe to the subacute versus acute. Stable is subacute, meaning they're hemodynamically stable and their pain does go away. Unstable, meaning they're hemodynamically, they may be stable, but there's no guarantee that'll last for very long because there's a very high risk of cardiogenic shock in these patients, which is another form of shock that is life-threatening. And they're having persistent pain. So despite changes in activity level, they're continuing to have chest pain, which is bad. Our big assessment things are pain assessment, PQRST assessments. We need to know all the details about their pain, especially the onset and kind of the timing characteristics. We want to determine, are they acute or subacute in their presentation of disease? Then electrocardiography, we need to get EKGs on these patients. There's very specific EKG changes that we're looking for in order to diagnose a problem of acute coronary syndrome. And then lab values. Things we want to look for, troponin. Troponin is an enzyme, we call this a cardiac enzyme. And it's something that's released by cardiac tissue when there's cardiac tissue death. Sorry, I said the same words a lot in there. But troponin is the enzyme that's released by cardiac tissue when it dies. So when there's an ischemic event, meaning that there's actual tissue death occurring, so there's tissue that's being deprived of blood flow, and that tissue dies, it will leak troponin. So the higher a patient's troponin level, we deduce that there's a greater area of infarcted or dead tissue associated with those patients. And then we also check our basic metabolic panel. We want to make sure that their kidneys are still working, that their electrolytes are all in normal range, or if they are out of normal range, that might be getting into part of the reason they're having a heart attack. So for our medical diagnosis, here's kind of the things we're looking at. First and foremost, screening. We want to know all about the history of that occurrence. Is it acute? Is it subacute? Was there any intermittent claudication, or has it been persistent chest pain for the last 30 minutes or so? And then what does their lab data look like? Troponin levels and their metabolic panel. Those are things we want to see very, very quickly. And then our non-invasive testing. This is part of our screening tool as well. EKG. These are done immediately. It's always one of the first things we do when patients present saying, I've got chest pain. Cool. First thing you get is an EKG, and then you're going to get your blood drawn. The thing we're looking for on these EKGs is there's a very specific abnormality in their waveform that is indicative of a heart attack, and that is our ST elevation. Here's what that is. So here's our normal EKG. This one's so normal, it looks like it was drawn by not a human. So yeah, very, very normal. This is ST elevation. So we're looking at the baseline right here. Right? So we have a consistent baseline all the way across this normal EKG. ST elevation, we're talking about our ST segment, which is here to here. It's from the end of our QRS complex to the beginning of our T wave. So when we have ST elevation, there's never a return to baseline after our QRS complex. Instead, it stays elevated and doesn't return to the baseline till after the T wave. That is ST elevation. We call this a STEMI, or an STEMI, which stands for ST elevated myocardial infarction. Once we've done our screening and we've identified STEMI in our patients, then we're looking for confirming diagnosis. The way we're going to do that, stress testing is one of our big ways that we do that. Exercise versus nuclear. If our patient can be active and get on a treadmill, we're going to do that to try and induce any electrical abnormalities that they may have because of that dead tissue that's part of their heart tissue. If they can't exercise, then we're going to do a nuclear test where they're going to be getting radioactive isotope to visualize blood flow in the heart, and then imaging to look at it. So that's going to be our two different ways of doing stress testing. What we're trying to do is replicate any changes in their EKG. So sometimes patients will present with ST elevation only while they're having chest pain. So if patients are subacute and their chest pain goes away, but they still show up for treatment, we're looking to reproduce those conditions that cause their chest pain. That's the whole purpose of stress testing. If they're showing up and still having chest pain and still having ST elevation, we don't need to stress test them because they're already stressed. This is just to try and induce or replicate this presentation, which is indicative of myocardial tissue death. If they have, or if we can find this ST elevation, then we're going to do coronary angiography. This is where we're going to directly visualize blood flow through the coronary arteries. This is an intervention that is performed very, very quickly because, sorry, a train of thought just totally derailed. Coronary angiography is the visualization of the coronary arteries. The angioplasty is when we actually do an intervention based on an abnormal finding when we do the angiography. So if we see an area of occlusion or of constriction of blood flow in one of the coronary arteries, they'll do an angioplasty at that time to restore blood flow. One of the important things to note here is as long as patients are having chest pain, they are having tissue death. So again, chest pain, bad. We always need to get rid of that. What this looks like, coronary angiography versus angioplasty, is this. So this is an angiography. So it's just getting the picture of the coronary artery blood flow. So what we do is, this is an arterial puncture that's done either in the wrist or the groin, and then that catheter is threaded back up through the body to visualize the coronary arteries. We inject dye into the patient, which helps us to visualize these arteries. So this right here is one of the coronary arteries, and you can see right here the blood flow almost looks like it goes away, but there's a faint little line where it goes and continues through circulation. This is a constriction. This is where this patient is having a heart attack. So what they'll do is an angioplasty where they'll do a stent to reopen up that section of blood or section of artery, and result is this. You can see right here, there's like a little square piece. That's the stent opening up circulation where it was constricted. So that's an angioplasty. We also call this PCI, or percutaneous coronary intervention. So it's just to restore blood flow to the heart. That way the heart can reperfuse that tissue and stop having chest pain. You can also see down in here, distally to where it's occluded, none of those supporting vessels, vasculature, have blood flow. So there is tissue death occurring here. After the stent is in, we can see all these other arteries feeding blood to that area of the heart that was deprived of circulation. So this has been a successful intervention for that patient. So for our nursing diagnoses, decreased cardiac output is kind of a slam dunk one because these patients do have cardiac tissue death, and a labile heart rate with activity. So labile meaning it wildly fluctuates. Patients can go from a heart rate, like a resting heart rate in like the 60s or 70s, and then with any kind of movement. Things like going from sitting to standing. Their heart rate will jump to like 110, something like that. Or just moving around in bed, going from a period of sitting still to being active in bed will cause their heart rate to shoot through the roof. So we want to look out for those labile heart rates. That is not good. Ineffective coping related to anxiety, definitely a thing. Nobody is a calm, cool, and collected patient when they think they're having a heart attack. This is always a scary, scary, scary thing for patients to be experiencing. So the medical management for patients with ACS or with having a heart attack. So first and foremost, lab testing. After our screening is done, we want to see those troponin levels. Normal levels, I think the top end of normal is like 1.2, I think, or no, it's 0.02. Excuse me, it's very, very low. Anything above that is considered a positive troponin. The more positive, the more bad. So we always want to get that troponin, and we always, first and foremost, get that EKG. We're not going to wait for troponin results to get an EKG. These two things are going to be done simultaneously, but the results are going to be done on your EKG first. Then stress testing, if their EKG is not showing the electrical abnormality, that ST elevation that we're looking for. Any changes while a patient is having one of these tests, that is bad. The escalation is then they will go straight into PCI or that angioplasty procedure in order to open up those arteries. Other things that are done, it's not super common, especially like in the city where we have access to cath labs where these procedures are done, but in rural settings you may still see this stuff done, is thrombolytics. So we can give clot busting agents to try and open up a coronary artery to relieve symptoms, but there's a narrow time window on when we can do that. They have to present and have definitive diagnosis within an hour of symptom onset in order to qualify for thrombolytic therapy. Anybody outside of that window, it's too risky to cause an embolic or to cause a bleeding event in those patients to give that therapy. So very, very narrow window in which we can treat those patients. So surgical management, PCI, right? So once we've diagnosed the problem, we know what's going on and they're outside the window to receive a thrombolytic, we're gonna go ahead and plan for surgery. They're gonna have that angioplasty PCI procedure. So we're gonna visualize any blocked or narrowed coronary arteries, and the goal is to restore blood flow to that area, just like we visualized in that image from the angiography. If this is unsuccessful, or for whatever reason their anatomy is such that stenting isn't possible, or patients who've had multiple stents, you can't stent on top of a stent. So patients with a very, very advanced disease, the next level of intervention is a CABA. Excuse me, I feel like I'm about to sneeze. So CABA is a coronary artery bypass and graft. So this is where we're going to restore blood flow to a section of cardiac tissue by transplanting a piece of artery from another part of the body to bypass the area of occlusion. So we're going to create like it's almost like a detour for the blood supply around the area of damage. And we only do this for when PCI can't restore blood flow. So they will do this quite a bit, those non-invasive or minimally invasive procedures, before we have full-on open heart surgery and CABA done. So this is kind of what PCI is, how they do it. So there's a puncture site into a peripheral artery. Common sites are the groin and the wrist for where we do the venipuncture to do the angiography. And then they're going to thread this catheter all the way back up the aorta to the coronary arteries, where they're going to inject this dye to visualize blood flow going through those spaces. Couple key things here is that puncture site, it's an arterial puncture site. So we need to be very, very careful that the patient doesn't lose vascular circulation around that or that arterial puncture. Once this procedure is done, we need to be assessing this site to make sure that they don't develop a hematoma, which is like a big, hard bruise inside the body. Hematomas are really bad because what they can do is occlude distal blood flow. So if a patient develops a hematoma in their groin here, all the circulation in that leg could be blocked because of the pressure that hematoma is applying to the area of injury. So we always need to do CMS checks to any extremity that has had PCI venipuncture done to make sure that we're not causing any occlusive injury to that patient from that procedure. Another thing to note is with the dye. One of the things we want to make sure our patients are aware of before they go for one of these angiography procedures is that this dye is radio opaque. That way we can see it on that X-ray to visualize the blood flow through the coronary arteries. But when we inject it, they are going to feel very hot and flush. It's like a wave of heat over their whole body. It can be very distressing for patients that don't know it's coming. Some patients state it feels like they're on fire. So do watch out for that. That's a negative side effect of the dye that almost every patient experiences. So we do want to warn them. It may feel like you're burning up on the inside when they inject the dye. Luckily, it's not a continuous injection. They only do it for very short little bursts of injection to see the arteries, and then they don't do that. So they're not continually exposed to that sensation. For CABA, this is kind of what we're doing. So we're going to harvest a vein from usually the legs. So usually like a popliteal area is one of the big sites where we harvest vein tissue for CABA. And what we're going to do is take out that section of vein, and then we're going to replace it from the aorta to distal. You can see this little highlighted area is what they're simulating as the area of infarct or the area of occlusion of the coronary artery. They're going to bypass from the aorta just downstream so that the rest of that heart tissue can have new supply of blood and be perfused. So what it means when people say single, double, triple, quadruple bypass surgery, this is what that looks like. So single is there's just one site from the aorta back to the blood or back to the heart. Double is where they have two areas of the heart that have infarct and they're gonna tap the aorta twice. Triple, 3 times, quadruple, hot freaking mess. They're all kinds of jacked up. Their heart sucks. That's bad. Bad. One of the big risks here is because we're messing with arterial circulation and grafting veins around the aorta, is anytime we make a nick or a cut in the aorta, anastomose or sew something to it, there's a risk of clotting. So risk of stroke is a big, big problem for patients who have CABA. So we always want to make sure that we're very diligent about anticoagulation therapy and management for patients who've had a coronary artery bypass and graft, this kind of procedure. So our nursing plan, so medical management. While medical management is still going on, symptoms of cardiac muscle tissue death need to be eliminated. Our goal always for patients having a heart attack is time is tissue, and as long as they're having pain, they are having tissue death. So we need to eliminate their chest pain as quickly as possible. Ways we do that, nitroglycerin times 3 every 15 minutes. So we give 1 tab of nitro. I wrote this kind of funny. Sorry, let me clarify it. So we give 1 tab of nitro sublingually every 15 minutes for a total of 3 doses. Not 3 tabs every 15 minutes. I wrote that weird. Sorry about that. One of the key things to look out for with nitro is a coronary artery vasodilator. So it's going to lower their blood pressure. So we need to get vitals before every dose to make sure that we're not crashing our patient's blood pressure by giving this medication. If we do start to see symptoms of hypotension, so their blood pressure starts to drop while we're giving nitro, we may end up giving small fluid boluses like saline to support their blood pressure because we need to prioritize getting their chest pain resolved. Then we're going to do ongoing cardiac monitoring. So serial EKGs. They're going to get their first one when they first show up to the department, and then probably one more right before they have PCI done. But then we're going to switch over to telemetry monitoring, which is our live, real-time EKG monitoring. So we're going to monitor their heart rhythm in real time for changes. And then stress testing to try and reproduce any EKG abnormality that the patient may have had prior to seeking care, but we're not appreciating or seeing while they're in treatment. Then comes our surgical management. So PCI is a big thing. Surgical prep is the name of the game here for us. We need to warn them that they're going to be getting that IV contrast. It's going to feel like they're burning or on fire when they get it. And then we've got to do, after the procedure, those very, very frequent checks of their groin or wrist to make sure they haven't developed a hematoma, which could occlude their blood flow downstream of wherever that procedure was done. If patients have had PCI with puncture in the groin, they do have to be immobilized for about 6 hours after the procedure. I mean, they have to lay straight. They cannot move that leg after surgery because with movement, it's going to bend around that puncture site, which can increase the risk of developing hematoma and bleeding. So we do immobilize it. For CABA, surgical prep is the name of the game. Let them know they're about to have open heart surgery. It's a big, big, big deal. The other thing to note is that because they're having open heart surgery, they may have chest tubes when they come out of surgery. That's to help with some of the surgical draining around breaking open the ribs, the pericardium, all that kind of stuff. So some of that thoracic bleeding or drainage will be managed with a chest tube after surgery. So implementation. When things are going good, we're doing MONA. MONA stands for morphine, oxygen, nitro, and aspirin. That is the acronym for what we do for heart attacks. Key thing with MONA. This is not sequential. This isn't step 1, 2, 3, 4. That's not how this is. This is like the a la carte menu, and you do whatever is appropriate at that time. Usually our first intervention is nitro. We do that till they get 3 doses or we relieve their chest pain. If after 3 doses we haven't relieved their chest pain, then we'll give morphine. So it's our second line treatment. Oxygen, current best practice is that we don't just put oxygen on patients. If they're oxygenating or appropriately, like their SpO2 is normal, we're not going to place oxygen on those patients. Aspirin tends to be an intervention that is done by paramedics. If they call 911, they'll give them a full strength aspirin, so 325. That's going to be definitely our secondary kind of intervention. First, we're going to try and get their pain to resolve. After that, then we'll give aspirin, and the reason we're giving that is really for the antiplatelet properties. Secondary stuff we'll do is look at giving beta blockers to reduce cardiac workload, help make it easier for the heart to beat, given that it's very stressed at the moment. And we're going to keep on this until their pain goes away. If things are going bad, they're going to have labile cardiovascular support, meaning their blood pressure, heart rate are not going to be stable. These are patients who are not hemodynamically stable. They could have wild increases in their heart rate with stress or activity, and they're going to have continued chest pain. Because with chest pain, time equals tissue, and as long as they're having pain, they are having tissue death. So we must eliminate the pain as quickly as possible. Thrombus. So one of the problems that occurs and one of the reasons patients start to have acute chest pain or acute myocardial infarctions is that they'll have a narrowing of the lumen of their vein, their coronary artery, that occurs because of atherosclerosis. Anytime that that's going on, there's a narrowing of that vessel. Any kind of blood clot which could be formed around that area of constriction could lead to a complete occlusion suddenly. And that's why we want to really worry about thrombic events. For evaluation of heart attack, how do we know when things are going well? First and foremost, stable cardiovascular system. They're hemodynamically stable. Specifically, their blood pressure, their heart rate are appropriate for their condition. We want to see those in normal ranges. We definitely don't want to see a low low blood pressure and a high heart rate, indicating some type of shock. That would be the opposite of good. And their lab work. So we're going to continue drawing troponins on these patients until we can observe a peak of their troponin level in their blood. Once we've found the peak and it starts to trend down, then we know that we have stopped tissue death from occurring. So we can start to kind of predict that we've improved the patient condition. Also, their LDLs should be low. So their low density lipoproteins, one of those measures of cholesterol, we need to lower that. And we're going to do that a couple ways. One is pharmacologically. That's going to be part of our plan. So they're going to be getting things like statin medications. The other is we need to do diet teaching for these patients. So specifically teaching them what a low-fat, low-sodium diet is, which is what we call a cardiac diet. So definitely brush up on what kind of foods would be low-fat, low-sodium. And then managing ongoing risk factors. So big ones that all patients who've had any type of surgical procedure are at risk for: blood clots. So whether they've had a stent placed, that foreign body in their coronary arteries, very high risk of clotting. So patients are going to be on antiplatelet medications long term. Also, we want to make sure that they don't develop secondary clots in their body, both in their legs or extremities, which would be DVTs, or in their brain, which would be a stroke. Definitely look out for blood clots in those patients. Hyperlipidemia, so that these drugs that we've started them on, or that their diet modification, we want to see that that works. So we want to make sure that their cholesterol is trending in a direction that's not going to reproduce an atherosclerotic area in their heart. And smoking cessation, because nursing school, smoking is the root of all other problems. And big deal for patients who've had a heart attack. We always need to teach them what to do if they suspect they're having another heart attack. When should they seek medical attention? When should they not seek medical attention? Pro tip, if they're having chest pain, seek medical attention, always. Cool? All right, so that's our heart attack section. Email me, text me if you guys are having any questions or concerns about this topic.